All right, so good afternoon and welcome to our CAHR lunch symposia. You are at the Canadian Immigration Policy and Healthcare Pertaining to HIV and Viral Hepatitis Symposia. So welcome. I hope you're enjoying your lunch, and I hope you're ready for what I think will be a superb opportunity to learn about Canadian immigration policy and clarify a lot of misconceptions that are out there. First thing, I'd like you to grab your little book, and there's a number of corrections. The first is Dominique. I want you to add a T to the end of her last name. I want you to write in Maureen Owino, who I'll give a proper introduction to in a moment. And I want you to cross out associate after Sharik Hayter's name. He's a full professor, but not full of himself. All right, so a little bit of background. It's been several cycles now of holding symposias focused on viral hepatitis. As we're all aware, there's a very, very significant intersection between the HIV epidemic and hepatitis C and hepatitis B co-infection. And Alex and Sharik and I have worked on putting these symposias together for a number of cycles, and we've also worked together to produce Canadian specific HIV, hepatitis C, and hepatitis B guidelines, along with a number of other people, many of which are in the room. This time around, we wanted to try and come up with a topic that was really relevant and significant to the HIV community, and I think we found one, and we've had the opportunity to work with George and Dominique in putting together this program. I'd like to thank the CIHR. This is in part supported by a meeting planning and dissemination grant. So thank you for that, and in particular to Andrew Matajic, who assisted with putting together our submission that was successful. Also like to thank AbbVie for helping to provide some support for this symposia. Okay, so I'm Curtis Cooper. I'm from the University of Ottawa. I'm an infectious disease specialist and a HIV and viral hepatitis researcher. My job here will be as the chair and to direct questions. This is Dominique Hélène Massenet. She did her training at the University of Ottawa in medicine and did a public health degree. She has been with the IRCC, Immigration, Refugees and Citizenship Canada, for almost 5 years. Okay, so we'll hear from her soon. George Giovinazzi, he did his training first in Imperial College in statistics. He did his medicine at U of Alberta. He also did training at the London School of Hygiene and Tropical Medicine, and he's been with the IRCC for 30 years. So we have a tremendous wealth of experience in this realm, which we're all going to benefit from. Next is Maureen Owino. She is one of my board member colleagues who has been with us for a year and just made a fantastic contribution. She immigrated to Canada from Kenya about 10 years ago? 12, okay. And she does all sorts of fantastic work in the community in Toronto. I can't describe it all, but she's the director of the Committee for Accessible AIDS Treatment, CAHR2018. Committee for Accessible AIDS Treatment is an organization committed to promoting the health and well-being of people living with HIV who are facing access barriers related to their status, using tools of education, training, research, service coordination, and advocacy, and as I'm sure you can imagine, has intimate personal and professional experience with this topic. Next to Maureen, we have Sharik Hayter, friend and colleague, an infectious disease and HIV specialist and researcher at McMaster. Alex Wong, friend and colleague, infectious disease specialist based in Regina, so has a different practice with many people facing barriers to accessing HIV and viral hepatitis CAHR, and he's also a faculty member with the University of Saskatchewan. And finally, Alice Singh from the University of Toronto, pharmacist extraordinaire, and she's had a very significant role over the years in these symposia. So the format will be as follows. I will stop talking soon and get out of the way. Then Dominique and George are going to spend about 30 minutes talking about immigration in Canada and policies. Then Alice is going to spend about 5 minutes talking about the many barriers that newly arrived Canadians face in trying to access medications, and specifically for antiretrovirals and the medications for treating viral hepatitis. After that, we will have a panel discussion which will be facilitated by me and you, because there'll be, I'm hoping, at least 25 minutes, if not half an hour, for individuals in the audience to ask questions, voice opinions, and have a discussion about some of the many barriers and concerns with this topic. So, having said all of that, I'd like to welcome Dominique.
Okay, good afternoon, everyone. So it's a great honor to be part of the CAHR conference, and actually it's a privilege to take part as a speaker as well within all the great speakers we've had thus far. As Curtis alluded to, George and I, we both work for Immigration, Refugees, and Citizenship Canada. We're medical officers in the Migration Health branch, and we work in a small division policy within the Migration Health branch. And we're hoping that through our presentation, you'll be able to better understand what our pre-migration screening processes are, as well as the policies that pertain to HIV and viral hepatitis. So I also want to add, si vous voulez poser vos questions en français, par la suite, sentez-vous à l'aise de poser dans la langue de votre choix, et la présentation est aussi projetée en français pour vous. Okay. Oh. Okay, c'est bon. We don't have any conflict of interest to declare, unless you consider working for the government as a conflict of interest, but otherwise we're pretty good. So again, in addition to what I just mentioned in terms of our objectives, we want to give you an overview of the migration context in Canada with some historical developments and other issues that have happened that's led to actually to an announcement that took place on April 16th of this year, which we'll get into in more detail. So on that note, I'll pass it on to my colleague George, who will get into the whole migration context and bring you through. Thanks.
Thank you very much. I'm very pleased to be here. I've attended several conferences, international conferences on HIV way back when they were being held in Switzerland by Stanford University, just when HIV was first coming into existence. And it's interesting to see what has happened over the last 20 plus years. I would like to say how impressed I am with the enthusiasm of all of the participants at this conference. I also noticed the ongoing theme of respect, protect, and fulfillment that seems to be running through many of the discussions that have taken place here. These are concepts that are close to the heart of IRCC. This is an interesting diagram of what has happened over the years with regard to immigration to Canada. Note the progressive increase of the proportion of immigrants in Canadian society. There are noticeable migration flows. If you notice the big hump there right at the beginning, that is the population of the prairies by people from Central and Eastern Europe. And at that time, most of the migrants that came during this time went into rural Canada to set up the farmlands of the prairies. There was then a subsequent leveling of immigration to the late 70s, And from about 76, 77 on, there was a sustained increase caused by the management of migration by the Government of Canada, and as reflected in the 1976 and 2002 Immigration Acts. Indeed, with the latest census from the 2016 nationwide census, 21.9% of Canadian residents were born outside of Canada. If you include the children whose parents were born outside of Canada, the rate is significantly higher. This is the very latest multi-year levels plan for immigration as announced by the government. This is the very first time where projections were extended beyond 1 year, and with this change of government, the government has decided to present to Canadians a 3-year plan for planned migration to Canada. A characteristic of the managed migration that I've mentioned already that started with the 1976 Act is the adoption of categories of clients rather than concentrating on countries of origin. Prior to 1976, favor for migration was given to people from the United Kingdom, the United States, and France. Okay. Subsequent to 1996, there was quite a marked change in our approach to immigration. Following this tabling of the annual report to Parliament on immigration that occurred in November, i.e. This slide, the effect is that, as you can see, leading up to this, we were bringing in about 300,000 permanent residents a year. The plan is to see 310,000 in 2018, 330,000 in 2019, and 340,000 in 2020. Although temporary residents are not represented in this diagram, with the recent geopolitical events taking place in the world, the numbers of temporary residents in Canada has increased significantly. For example, Canada is rapidly becoming a favored country for overseas students. Let us now look at who are the recent immigrants that are coming to Canada. As I mentioned, prior to 1976, the emphasis was on the United Kingdom, France, the United States. Since then, we can see what has happened. These are where were recent immigrants born. What is striking here is the demographics of immigration has shifted quite sharply towards Asia. Keeping this in mind, I would like to now present a series of slides showing the incidence of the viral hepatitis and HIV. This is an example of hepatitis C, and as you can see, much of the hepatitis C is in Asia, the Middle East, and Northern Africa, and parts of South America. The prevalence of hepatitis B again reflects the Asian and African reality. And with regard to HIV, we are looking at Africa, parts of South America. You will also notice that the Philippines has quite a high incidence of HIV, and perhaps if anyone wants to discuss this, we can discuss this after the discussion. I was there at the time when this country was changing to a point where HIV was becoming a real issue. As you can see, globally, migration flows are increasing in magnitude. Geopolitical events have contributed to the growing complexity of migration flows in the world. Like many Western countries, population growth is dependent on immigration. The reality is the birth rate in Canada is below 2. For each woman, it is below 2. It's somewhere in the region of 1.56 to 1.86. Without immigration, the population of Canada will not grow. If we look at this, we can see also patterns, the recent patterns that are taking place geopolitically. As an example, in the Americas, Mexico is now a net receiving country for migration, for migrants. And it is coming, the migrants to Mexico are coming from both its northern border and its southern border. What is evident is that, as I've already mentioned, that migration from Western Europe is no longer a primary source of immigrants, and Canada, unlike Europe, is relatively isolated from some of the really critical migrant flows that are occurring in the Middle East and Africa. Now that the context is established, we'll look at how Migration Health Branch functions within the Immigration Department. Note our health mandate, which is to contribute to the protection of the health of Canadians and promote the integration of immigrants. We actually take this fairly seriously in IRCC and in Migration Health Branch. And the way we do this by setting up regional medical offices where there is a Canadian medical doctor who works for IRCC who supervises the health aspects of migrant flow in the world. For example, RMO Ottawa covers the Americas. The London RMO covers, the RMO, by the way, is the regional medical office. The London RMO covers Europe and Africa. The Delhi RMO covers West Asia and parts of the Middle East. The Manila RMO covers East Asia, including China and the Pacific. What's important to understand is that we function under the current legislation, i.e. under the Immigration Act. And we are subject to the Immigration Act, and we do not have the ability to deviate from the Act. The IRPA, which is the current Immigration Act, is the successor to the 1976 Act, and it created the concepts of economic, family, and humanitarian movements with regard to immigration to Canada, and has become a structured immigration system. This is a fairly important slide. It's a bit complicated. Under our current legislation, when we look at medical aspects of migrants who are coming to Canada, we have three things we consider. One is public health, the threats to public health, the threats to public safety, and concepts that are referred to as excessive demand. What is public health? Public health, for all intents and purposes, refers to active pulmonary tuberculosis because it is a significant public health threat that is passed on casually. You cannot stop breathing, and it is the air you breathe out that can infect other people. So that is one aspect, and that's our most important aspect with regard to public health. Public safety, on the other hand, refers to, as you can see there, refers to conditions where there is the risk of sudden, unpredictable, or violent behavior that can actually injure others and is a danger to the health of other residents. This, in actual fact, is used extremely rarely. Most of the time, this is related to criminal activity and so forth, and it is the criminality that leads to inadmissibility to Canada rather than medical concerns. Displacement refers to conditions that would increase the morbidity or mortality of Canadians on waiting lists. Examples include individuals who require kidney or liver transplants. As you know, Canadians on these lists do die prior to the time they are able to access a transplant. To put numbers in context, of all of the immigration medical exams that are done throughout the world, and right now we do approximately 500,000 immigration medical exams, less than 1%, way less than 1% are medically inadmissible. Okay, so if you're playing a gambling game, if you have to undergo an immigration medical exam, the odds are really stacked in your favor. I would like to point out how we do things here. There are two main steps involved with regard to medical screening for immigration. For all permanent residents to Canada, regardless of where you are, you require an immigration medical exam. It's established by statute. You can't get out of it. Okay. Immigration medical exams are done by physicians that exist throughout the world. They are not IRCC employees, but they are physicians that are nominated or not nominated is the wrong term. They are physicians identified who know the IRCC requirements for immigration, and they do the physical examinations of individuals, of migrants coming to Canada, and they forward this material to the regional medical office. The examination consists of the standard medical history, physical examination, looking for symptoms, the so-called functional inquiry. With regard to laboratory investigations that are done, there's a urinalysis if you're over age 5. There's a chest x-ray for everyone aged 11 or higher. This is the looking for active pulmonary tuberculosis. And there is HIV and syphilis screening that takes place at the age of 15 or older. Once this is all collected, including subsequent specialist reports, so that there is a much better understanding of what the medical condition is in the applicant, this material is sent electronically to one of the regional RMOs, and it is someone like me or Dominique, an employee of our IRCC, that reviews these documents and provides an immigration medical assessment. It is the immigration medical assessment that is given to immigration to determine medical admissibility or inadmissibility or any other conditions that may be imposed on the client. I would like to now compare how we look at HIV and viral hepatitis. With regard to the screening, I've already pointed out that HIV testing is done as a routine for everyone aged 15 or older. If a client is discovered to be HIV positive during the screening process, they undergo counseling. Counseling done in the overseas setting is quite challenging because it depends on where you are and how you can deliver counseling. In certain countries, counseling can only be done legally by someone who has been trained by the local government and has received an official certificate from the government on how to do counseling within that jurisdiction. Our tendency is to push the UN AIDS concepts of counseling outside of Canada. With regard to counseling inside of Canada, that is left at the level of the provincial and territorial, each province and territory. We then, as I say, once all of this is done, we do the immigration medical assessment. Okay, we do not do the immigration medical assessment until a counseling has taken place. We then communicate the material to immigration, and if a client is found to be medically admissible, they are actually given a handout on how to access HIV care and treatment inside of Canada. They are given various phone numbers to call. They are asked that if they do not speak English or French, to try and get someone who can translate for them that they know and that they trust. And the whole purpose of this notification process is to provide a continuum of care, because virtually all clients that were discovered to be HIV positive, they are referred to a specialist locally, and with very few exceptions, they're all started on treatment. And so what we want is them to be able to arrive in Canada and continue with their treatment uninterrupted. There is a subsequent notification. When someone arrives in Canada from overseas, we do searches to determine who has arrived, and we give a nominal report to the provincial public health authorities if we know their address, so that the provincial public health authorities can ensure that they are contacted so that they are able to see an appropriate infectious diseases specialist so that they can get appropriate ongoing HIV treatment. In contrast, for viral hepatitis, we do not have mandatory screening at this time. We are strictly dependent on what the history is that the client tells us and if there are any physical findings that suggest viral hepatitis. Counseling is done at the local level where the client is done, and for that, we have to be very dependent on what the local specialist counseling given by the local specialist according to that country's norms. The immigration medical assessment is then done, and vast majority of cases are medically admissible. We do not have formal communication tools to give to the client when they arrive in Canada, and we do no notification to the provinces for these clients who arrive. This is a very busy slide. I'm going to try and go through it fairly closely. This is almost a repetition of what I've said already. The client applies to come for applies for a visa to come to Canada. The immigration application is refused and medical instructions are issued, i.e. the client says, I want to come to Canada, I want to come under this category, and the visa office issues medical instructions, go see this particular individual and get your immigration medical exam. The examination is completed, and it, as I've already said, is submitted to the regional medical office, and if the client is HIV positive, it has to include specialist reports, it has to include treatment protocols, etc. The immigration medical exam is reviewed, an immigration medical assessment is provided. Vast majority of cases, again, I'm going to emphasize, is clients are admissible to Canada. The client enters Canada at a port of entry. We in immigration then search for the clients that enter at the port of entry. We do that about once every 2 weeks. And if at the port of entry there is a record of where the client is living in Canada, we will notify the province, the public health authorities in that particular province to ensure that the client is assisted in accessing HIV treatment in Canada. Part of the problem we have with this is about 40% of clients are examined inside of Canada. Once they are examined inside of Canada, the situation is different. They do not enter a port of entry. For example, people that are seeking asylum receive their immigration medical examination in Canada, and we're very dependent on the local, provincial, and territorial methods of associating a client for HIV care. Could I ask you to take over now?
All right, thanks, George. So I'm going to go now in a different direction and essentially speak to some of the objectives the Migration Health Branch wants to achieve. One is the process of reviewing relevant evidence to pretty much understand and frame how we manage HIV and viral hepatitis, especially in the pre-migration context, which is applicable mostly to us. Now, that being said, working in the policy sector within Migration Health Branch, there's definitely a lot of thinking around how we can ameliorate current policies, and currently what we're doing is reviewing internal analyses that are being conducted, partnering with other government departments such as Statistics Canada, for instance, and obviously reviewing the known evidence with regards to HIV and viral hepatitis. So this is essentially a table demonstrating the number of HIV cases that are reported to provinces, and those are among migrants. We can observe here that most of the cases are represented among the young individuals. Slightly more than half are male, and they originate from countries that are striving actually rather to achieving the WHO global targets for sustained viral suppression. Now, as George alluded to earlier, 40% actually get their IME done in Canada. And the expectation there is that if they are seen within Canada, is that they're linked to appropriate HIV care. Now, this is another view of cases of viral hepatitis and HIV that are actually found through the IME, or the Immigration Medical Examination. And we've subdivided those individuals into those who are admissible and inadmissible. And within the group that is inadmissible, we've also divided it further for those who are inadmissible on health grounds and inadmissible on other reasons than health grounds. And you can see for HIV, for instance, that only 5% of the 27% refusals, that's the orange slice that you see there, are based on health grounds, whereas 73% of those migrants with HIV are actually admitted to Canada. Now, if we talk about hepatitis B, that's around 0.5% that are refused on health grounds, and hepatitis C has a proportion of around 2% refusals on health grounds. And just to reiterate that the blue slice that you see in those diagrams as well, they represent the reasons other than health why someone with viral hepatitis or HIV would be inadmissible to Canada. And again, taking into account what George was saying in terms of those who are routinely screened or not, interesting to take those considerations into account when you're looking at these numbers. Now, when we, if we keep the previous slide in mind, RCC, Statistics Canada, and other hepatologists interested in migrant research have collaborated to look at hepatitis-related hospitalization among migrants in Canada. And the reason to do that was to look at and assess the burden of these conditions among migrants, evaluating potentially hospital stays and number of hospitalization per case for liver-specific disease, and taking those findings and actually comparing to Canadian-born or long-term residents in Canada. And again, represented in the table here is a distribution of cases of hepatitis B and C between migrants and Canadian-born and the long-term residents by several characteristics, such as age, sex, country risk level, and country of birth. And as expected, hepatitis B cases are actually more represented here among migrant groups, whereas in contrast, hepatitis C related to hospitalizations are what's most prevalent in Canadian-born long-term immigrant residents. Now, for both groups, we see here that males were prominently represented, and as predicted as well, medium to high-risk countries had higher proportion of cases. And that's what the arrows show here. Now, if we go one step further and look at those cases and consider the comorbidities and sequelae related to hepatitis B and hepatitis C infection among migrants, interestingly here we see that in migrants there's little hepatitis and HIV co-infections. And for us that was something noteworthy to take into account. Okay. This is just a slide representing that there's obviously a whole bunch of evidence, let it be primary research or guidelines that are reporting on how we should be looking at optimizing viral hepatitis care and therapeutic outcomes in immigrants and refugees. And essentially, IRCC, specifically Migration Health Branch, has taken note of that mounting evidence, and really what we can see is that, for one, there are delays from time of arrival into Canada for individuals to then engage with hepatitis C related care that would essentially lead to missed opportunities to treat and cure hepatitis C patients. And additionally to that, earlier engagement through the immigration process would optimize hepatitis C care and therapeutic outcomes. Early recognition of chronic hepatitis B would definitely extend lives of those who are infected among migrants. And if we had more targeted screening of migrants who were disproportionately affected from chronic hepatitis B, that definitely would be a public health impact or public health benefit for that group. Now, after reviewing some of the evidence or some of the things that we're thinking about or reviewing, we are also undergoing at the same time, excuse me, a review of the excessive demand policy that George was actually explaining in more detail earlier. And it took around maybe a 2-3 year process where it started off with an internal review and evaluation of that policy that started at the end of 2015. That led to identification of issues that were identified, such as the lack of PT engagement with regards to this specific policy, as well as operational legal challenges that we found when administrating this policy, even though it involves a small number of individuals. In addition to that, or what followed was a consultation that took place with key stakeholders and provinces. And following that, there was also a specific standing committee, a citizenship and immigration in cabinet, that made a study around this particular topic and provided specific recommendations that RSCC needed to respond to, which actually led to the announcement and the government response that occurred on April 16th, 2018. And essentially what that involved, or what that led to, was now the cost threshold for medical inadmissibility is now tripled. And the definition has been amended so that social services, such as rehabilitation, social and vocational rehabilitation, personal support services, they'd be referred differently. Essentially, those who would be considered medical admissible would have those barriers essentially when they could come to Canada, rather. And when it comes to HIV and hepatitis, viral hepatitis, this change in policy significantly impacts individuals who would bear those conditions. For one, it's the fact that there wouldn't necessarily be refused based on cost, which was usually the main reason why someone would be considered medically inadmissible if they had HIV or viral hepatitis. So it's definitely something that we need to take into account, especially when we think of how we currently do our screening practices and how that would actually impact provinces who are notifying, et cetera. And if you think back to one of the diagrams we were looking at before with the slice, the orange slice, blue slice, et cetera, essentially that orange slice would mostly disappear because there wouldn't be necessarily any grounds for refusal. Now, when it comes to the impact and evolution of HIV and viral hepatitis health screening practices, in the pre-migration context, it gets us thinking about, okay, how we might be able to, first of all, ameliorate the current HIV model, given what we know, and can we actually think of using it to inform how we do specific viral hepatitis screening and potentially care that follows, and the services that are provided post-arrival as well. In the context of our mandate, where we're thinking about how to best approach this screening practice, risk mitigation is definitely one that we're considering, whether it be a lesson, a burden on how we, or weight we put on admissibility and admissibility, and focusing more on how can we mitigate risk and encourage more integration into Canada, even though they're aware of their hepatitis status, and it wouldn't become a barrier that way as well. And when I consider, when we consider all this, and in view of all that's been presented thus far, essentially there's a lot of questions that arise and that need to be examined. And there's just several here that are listed, but again, we could speak to so many more questions here. For one, how does pre-migration health screening contribute to the WHO goals to address HIV and viral hepatitis global rates, given, again, the new approach to this policy of excessive demand? Should we systematically screen for viral hepatitis? And if we do screen, what do we do with the results? And how will we follow up with these individuals, et cetera? What would be the public health impact of systematic screening of viral hepatitis in Canada? Additionally, with the new approach with the excessive demand policy, how best can we engage with all relevant stakeholders and partners for expected increase in notification of HIV cases and viral hepatitis for that matter? And again, if there's any ways for us to improve the current cascade of care when it relates to the current HIV model that we're using. So these are just several questions, but obviously there's other considerations that could be taken into account. Okay, so this leads us to the end of our presentation, where we wanted to be sure to essentially give some context to the migration trends, immigration levels that are increasing, for sure for various immigration classifications, and especially considering that recent migrants who originate from high HIV and hepatitis virus burden regions. Presenting to you, for those who weren't aware of the announcement of the new approach and what implications are related to that when it comes to screening processes. Thinking about new opportunities of how we can engage more into health risk mitigation for improved immigrant health outcomes, leading to better integration in Canada. And lastly, and importantly as well, encouraging further engagement and support from partners and stakeholders for advancement of the overall causes of addressing HIV and viral hepatitis in order to reach our WHO targets. And that's pretty much it. Merci beaucoup. On est prêt à recevoir vos questions.
All right, so thank you very much for that, Dominique and George. So I hope that we all have a solid understanding of the process involved in immigrating to Canada and some of the considerations as they pertain to HIV, Hep B, and Hep C. And thank you for highlighting some of those key questions, which we'll dedicate the second half of our talk to. So the person has now arrived in Canada, and there's many challenges and barriers to accessing care. One of them is on the medication end. So Alice is going to come to the podium now and spend the next couple of minutes highlighting some of these issues.
Thank you. Oh, thought I saw something quickly there. Okay, what was it? Okay, thank you. What I've been asked to do over the next couple of minutes is just give an overview of how new arrivals to Canada can access drug coverage. So I'm going to be talking mostly about the Interim Federal Health Program, the IFHP. The purpose of this program is to provide limited temporary coverage of healthcare benefits to resettled refugees, refugee claimants, and other groups. And so this includes full health care coverage, including both basic, supplemental, and prescription drug coverage. The program is the payer of last resort, does not reimburse beneficiaries directly, so that's important for people to know. They can't expect to pay out of pocket and then get reimbursed. And the service providers and pharmacies who provide the service need to be registered with Medavie Blue Cross to be approved providers. And there's quite a large section on the Immigration Canada website on this. Now, in order to qualify, people need to have one of two forms, and I want to thank Linda Robinson for providing this slide for me. So you notice that there's either a refugee protection claimant document or a certificate. One thing, and so they would go to a pharmacy and present this documentation. One thing to be aware of is that if there's a date of issue or a date of expiry on this form, it's not related at all to the validity of drug coverage. Usually that date is just an indication of when they have entered the process for their status. But it's really incumbent on the pharmacies to make sure each time that someone's coverage is still valid. Now, prescription drug coverage through this program usually is for 12 months from the date of arrival in Canada. And it terminates as soon as the client is no longer IFHP eligible. So again, as I stated, the expiry date on their immigration document may not reflect the current status. So people do need to check each time before they fill a prescription. And this can be done by either going through the secure provider web portal or the call center, and you use the client ID number on their immigration document. One sort of newer change is that coverage now mirrors what is on the provincial and territorial formularies. So most antiretrovirals will be covered. Some of the directly acting antiviral therapies may require prior approval. So a prior approval request is needed, like I said, for most special authorization drugs like hepatitis C agents. These requests can be made over the phone or by fax or electronic submission. I know people who've called and gotten a response right away on the phone, but it can sometimes take up to 1 week to hear back. There may be an expiry date for this approval depending on the drug. So again, often for Hep C drugs being so expensive, there can be an expiry date. So you do need to, for pharmacists, they do need to ensure that that last 28-day supply is filled before the expiry date. And again, just if a person's IFHP coverage terminates prior to the expiry date, the drug approval will also end. So that, again, determines everything. Now, where to find out about how different antiretrovirals and DAA drugs are covered throughout Canada, I'll direct you to two resources. One is our immunodeficiency clinic website, which houses a number of documents, including information on drug reimbursement. On the sort of middle bullet point here under drug reimbursement, there's a fantastic chart put together by a number of colleagues across Canada, which will tell you exactly for all the different antiretrovirals how they're covered in each province. CTAC also has a resource developed called the Treatment Map, where you can go online and click on your province of interest, and it has information on coverage for both HIV as well as hepatitis C medications, and it's quite an extensive resource. It will bring you to links directly to that province's formulary site. And finally, I just wanted to draw people's attention to a poster put together by my colleague Alison Wong from Montreal. It's being presented this afternoon. And just to be aware that, in fact, certain changes or interruptions in policy or procedures can have a very real impact on continuity of care. So they looked at the impact of changes in federal policy on access to antiretrovirals in asylum seekers and refugees at their clinic over 2 time periods. And not to steal their thunder, but they did note that there were, due to these sort of outside changes, a lot of additional efforts were needed to secure or continue antiretroviral therapy. There were a number of people who had to miss or who wound up interrupting therapy and in some cases developing a detectable viral load. So I'm going to stop there.
So thanks a lot for that, Alice. So thus far, we've covered all the formal, structured, the nuts and bolts of how new arrivals to Canada get here. And but Alice started to get to the point where, of course, it isn't just sort of a black and white nuts and bolts thing. These are really real people who face all sorts of barriers. And Sharik and Alex and I as clinicians see this every day in our clinics. But I think Maureen, given her work, has the best and most important insight into this. I'm wondering if you could start off our discussion by just talking about some of the the barriers that your clients are facing when they arrive in Canada. And as Maureen is speaking, if others in the audience have questions, if you could stand and identify yourself, and we'll try to get to as many questions. Anybody on the panel is fair game, and you can ask whatever you like or raise any concerns that you may have.
So, as was earlier, my name is Maureen Owen. I work with the Committee for Accessible AIDS Treatment, and we do work with immigrants, refugees, and undocumented people living with HIV. And thanks, Dominic and George, for the wonderful presentation. So I think for me, listening to that presentation, actually both of the presenters this afternoon, some of the key points coming up for me in terms of, I think, immigration, and you did really identify that some of the new immigrants currently coming to Canada, international students, and there's a lot of them. So for example, Ontario receives approximately 150,000 students a year, and how the process of immigration goes for them. I think CAHR has undertaken a study because we've really seen a lot of students getting infected with HIV, and based on the, and maybe my question is in terms of even the visa application, I would love some clarity about what kind of information is shared with, because we've seen students who've been diagnosed before they came into the country and those who've been diagnosed here in Canada. So those are two different populations, and what the processes are for those students. And also internally tested HIV positive immigrants, because there's really a big group of immigrants who probably came to Canada through visitors visa, students, migrant workers, or other forms of migration processes, and get diagnosed while they're inside. And they go through the immigration process while they are in the country. And we've really seen a lot of challenges with these populations in terms of even the migration process and acceptance rates. And those acceptance rates that were on that PowerPoint of, I think it says only 133 are inadmissible on health grounds out of 1827. It's an interesting number. And so really specificities about that. And I think something else that comes to mind is, and it's same coming to this, is the counseling processes. Committee for Accessible AIDS Treatment a few years ago, in partnership with Dr. Darrell Tan, and I hope he's in the room. Darrell. And HALCO did a whole research study and a training program and a survey and consultation with immigration doctors, then known as DMPs, designated medical practitioners, and the names have changed now, on the processes of testing people for immigration. So one of the things we really did identify was the counseling, post-test counseling does not take place. It's not really appropriate, it's not effective. And we did develop a referral form to be handed out to people who've tested to kind of mitigate some of those challenges that were identified. And yes, the doctors told us they do not have the time and the resources to provide that counseling. Very clear, and we've written papers on it and this. So I'm curious, has something changed? Has there been more training in terms of how counseling is being provided by the immigration doctors, both overseas and here? And because in looking at the holistic framework and how people get tested, yes, treatment is important, and we can talk about that later, but also there's the pieces about even the referrals and what kind of information is given, because one thing we've seen is people are just told, you can be criminalized for having sex without disclosing. That's basically what the counseling has been. So these are, for me, the questions that come up in listening to this presentation for now. So Sharik and Alex, maybe you can comment
some of the issues faced by new arrivals in your clinics, some of the frustrations that as physicians and healthcare providers we run up against in trying to provide proper care for these folks.
Sure, so I'll get it started and then pass it over to Alex. So maybe I'll give you a bit of a framework about our own clinic. So I work in Hamilton at a clinic that went through actually a bit of a demographic shift because Hamilton had for a while become a preferred site for refugee allocation. So we started seeing a lot more, should we say, clients from West Africa, continental Africa, and the immediate impact on the clinic was very much about recognizing that we needed to expand the resources that we had within the clinic. Clearly, one immediate example would be language. So in my clinic, we actually have one French-speaking physician. And certainly that was an immediate need that needed to come through. Certainly the importance of having translators available became a need within the clinic. And then the recognition that there are obviously unique issues that come in with our refugees that do come forward. There's a lot of social stigmatization that comes forward. We realized as a clinic that even though we were a freestanding clinic, there were many folks that would come that really were hesitant to come to the clinic. It was the idea of being seen by a fellow community member within the clinic. It was actually even a bigger issue trying to link them to frontline primary care, where the concern was even higher. So in fact, they preferred to actually come to our clinic for management. And the reason I highlight that is our clinic, as an example, is a clinic that's run mainly by specialists. We're not a primary care clinic. They're all either infectious disease specialists or medical microbiologists. About the same time, some of you may remember that when the IFH cutbacks took place in 2012, I thought I'd just speak on that because we certainly saw the immediate impact of that. You've seen a poster that Alice highlighted, but there was a report that was put out by the Wellesley Institute. I'm sure some of you may be aware of that. And that institute had done an analysis to look at what the impact of IFH reductions was. And they were dead on. One of the things that they highlighted in their analysis was that the impact of IFH, if anything, would translate into higher costs. And one surrogate marker of that was actually emergency room visits. And in fact, in Hamilton, I wear a number of hats, and one of the things that I got alerted about was just that fact. We were seeing a lot of emergency visits by folks coming in, and again, the failure of emergency physicians in recognizing, shall we say, the complexities that were built in. Certainly a rise in chronic disease burden was seen. Mental health issues were going unrecognized. And so I think that just deserves a bit of a recognition because that report was ahead of its time and it really did highlight what all of us as frontline physicians were seeing. So I'll hand over to Alex.
Sure, so thanks, Shriek. I mean, I think in our neck of the woods in southern Saskatchewan, we've had an uptick in the number of immigrants and refugees coming, and I think overall, truthfully, we have a reasonable setup. The places where people are going most regularly, which is our city of Regina, as well as our sort of sister city, which is about 45 minutes away of Moose Jaw. There are immigrant sort of open door society clinics that are set up that essentially everyone is encouraged to attend and is engaged in a primary care setting. And screening is done in those settings regularly, regardless, I believe, of whether or not someone is known to be positive or not. And then linkage to care sort of occurs through a combination of our colleagues in the Open Door Society, as well as our colleagues through public health. And so, again, I mean, I think our numbers are small compared to larger clinics like, you know, Toronto or Ottawa or Vancouver, but overall, I think the processes that we have in place are somewhat reasonable. We have had some challenges with a small number of individuals who were deemed to be medically inadmissible because they were found to be positive for hepatitis C. And this was individuals specifically that were diagnosed inside Canada rather than outside Canada. So for me as a clinician, it was a little bit confusing as to why certain individuals were being admitted to the country and viremic, obviously viremic with hepatitis C, and then were admissible, and then others were inadmissible. And the numbers were small. It was only 2 individuals that I personally dealt with as a clinician. But essentially, these individuals who were otherwise very productive, or at least what we would believe to be very promising, productive members of society, were given a letter that essentially said, you're going to be thrown out of the country unless, you know, this is dealt with in some way. So I had to basically go to industry and ask for compassionate medication to be provided to these individuals so that they would not be basically told to leave the country, and fortunately we were able to make that happen. So again, I mean, for me as a clinician, trying to get some, having some clarity around the processes and why sort of there seemed to be these one-off cases was a little bit confusing. But overall, as I say, I think our processes are not too bad.
So you raised the issue of hepatitis C, and in our clinic, when we looked at our numbers, a median 16 years passed from the time of arrival until the time that they set foot in my clinic, which would be their first opportunity to have a proper evaluation for hepatitis C and have potentially access to treatment. And a lot of bad things can happen to a person with 2 decades of unrecognized and untreated hepatitis C. So there's the linkage of care issue. I'd be interested in people's opinions about that. And there's the question about should we be screening for hepatitis C just like we currently do for HIV. I think you know, clearly you need to balance the importance of stigma by screening somebody for an infection like hepatitis C, but that needs to be balanced about the consequences of a person going for decades with undiagnosed and potentially very serious consequences of undiagnosed chronic viral hepatitis. So I don't know who wants to tackle that one.
I think it makes a lot of sense to screen, and I think if we're already screening for bloodborne infection like HIV, then I think it makes a huge amount of sense whether or not we want to target screening for our individuals who are coming from higher prevalence settings or have some sort of a rational approach, or whether or not we simply want to consider screening everyone. You know, now I think across the country with restrictions being removed for direct-acting antiviral therapy for hepatitis C, essentially diagnosis is akin to cure. Accessibility for drugs is no longer an issue here in Canada, and I think for all of us who treat hepatitis C, this is remarkable. We didn't believe this was going to happen anywhere near as quickly as it did. Now the issue is diagnosing and engaging people in care, and in my mind, if there's an opportunity to systematically diagnose people and engage them in care and cure them before they face sequelae of you know, long-standing viral hepatitis, then I think we should take advantage of that.
So I'll echo the same comments as a frontline clinician, someone who's been treating hepatitis C for a long time. In fact, if you look at the statistic that Curtis just handed out from his study, if there's a median of 16 years in these patients coming in from the time they're being engaged in clinical care, if you look at the natural history of hepatitis C, you would predict that many of those people had advanced histological disease. So if you think from a cost perspective, because you said one of the key elements in policy development is the impact on the health and welfare of Canadians, and obviously the economic impact, there would be great rationalization to actually picking these patients up early so that, in fact, if anything, we're not increasing the impact of late presenting hepatitis C cases.
Is there anybody out there who, okay, and do we have a mic? So if you could try to be succinct in your comments and questions, that'll allow as many people to have a chance to contribute. Okay.
There's just a few people at the back as well, back here,
Yeah.
for those that have a mic. Please, would you mind? Thank you.
Hello. Hello, my name is Antonio. I just came to Canada in 2012, completed a master's degree in Victoria, graduated and applied for the provincial nominee program. I obtained the nomination and applied for permanent residence. and I am in the nightmare of the medical exam. The doctor spent 6 weeks for getting my HIV results and for counseling after 20 years living with HIV, having a counseling in HIV. I appreciate that, but I think that step we can skip it. And now the doctor cannot send the report because my doctor is not an HIV specialist. And I don't know how the government authorized a doctor who can prescribe my medications and treat me as an HIV positive person and doesn't allow the doctor to make a report for immigration. Is that difference between treating a person and sending the report? So but the next step is going to be, I don't know, in the nightmare. I am in the middle of something. The federal officers in Ottawa talk to the doctor, and other officers in Sydney, Nova Scotia, talk to me, and I am in the middle of that lack of coordination. So it's a nightmare for me.
So thank you for raising that. And I mean, it really, I think different people have different experiences, but you raise this very important and unfortunately frequently encountered situation where people are trapped in between big bureaucratic systems that don't seem to be able to communicate with each other. And I thank God for my social worker, Esther Cloutier, who's able to act as a conduit, because this takes a lot of time to try to sort out. Another question? Oh, in the back there. I'm confident that our immigration system works better than the microphones.
Let me go ahead and then.
Test.
Let me go ahead and then we can pass at this point.
There we go.
Oh, it's working now. So my name is Wangari Tharao, and I work in a Women Health Center in Toronto that actually provides primary healthcare services to immigrant, refugee, and non-status women from Africa, the Caribbean, Latin America, and South Asian women. And a couple of people have raised the issue of the time people come in knowing they're positive, and the time they get linked to care. Sometimes it takes years. And if you find out from people who got tested outside Canada, they will tell you they got a brochure with an 800 number. And they're supposed to link with care through calling that number when they enter into the country. And people wander around for years without linkage into care, just because an 800 number, they have no idea who is at the end of that number, and people are scared, and a number of people raise the issue of stigma and discrimination and all that stuff we're all aware of. And I'm wondering if you can think of a better mechanism of linking people to care, putting some face onto that brochure. I know in Ontario there's a, for African, Caribbean, and Black populations, there are organizations that have gotten together to actually develop a booklet that is given to newcomers as they enter the country, with numbers and organizations which they can call. And I'm wondering if CIC can actually come up with something, a strategy like that, so that people can actually see names and numbers for linkage to care when they enter into Canada. The other piece for me is people who get tested inside the country. Some of them get tested when they're living in shelters. And before the results catches up with them, they have left. So they have no way of actually being notified that the results turned HIV positive. And it's only when eventually they figure that maybe they end up at the immigration hearing, that's where they're learning about the HIV positive test results and trying to figure out how do you ensure that when people are tested, eventually the results are actually given to them.
Okay. So you've raised some very important points, so thank you very much. I think George and Dominique wanted to briefly comment on that, and then we'll go to the next question.
In terms of your first question, in terms of the information provided to someone migrating to Canada who's been newly infected with HIV or discovered to be infected with HIV, I mean, the ideas you bring forward are quite interesting. It's interesting on our side because when we go to provinces and request who should be the main contact individuals that are supposed to make the linkages when someone arrives into your province, they're the ones providing us with this contact information. So I don't know if it's a breakage of communication or if there's just another opportunity for us to assess those contacts. There's definitely opportunity there for improvement, that I agree. If there's maybe a way for us to provide further information for those linkages to be made as well, if it's a booklet or something that's done online, I think those are where the ideas can come forward, but we're not necessarily close to those ideas. I think what we can do from our perspective is we have a specific unit called the Public Health Liaison Unit, and they're the ones responsible to pretty much connect with the provinces and ensure that all HIV notifications are made, especially if they have the address of the individuals, where they're going, etc. It's when, let's say you're missing an address, you're lacking information to get in contact with individuals, we're actually caught as well. Although we have this result in this IME application or immigration medication application, if there's lacking information, that also doesn't help our situation. So various aspects to that issue. That being said, though, I know that our current unit is looking to see how they can best ameliorate those type of communication tools. Now, one thing I could say is that when we could bring back is there an opportunity for us to revisit that contact list that you're referring to and see how we can best ensure that people are getting connected? I know there's the second part of your question in terms of the individual who was in shelter and kind of lost track of that individual as well. I think George wanted to.
Yes, this is a problem when people change location in Canada. We have no way of determining where that individual has gone until they contact us. And it's only when they contact us with a new address that we're able to get a hold of them. And this is a problem we have dealing with many clients. Many clients have the idea that if they do their initial immigration medical exam, get the blood work done, they move on to another location. They don't let anyone know. And it's only when they inquire far down the line saying, you know, what is my status, what is going on, that suddenly we're aware of what they are. And it's only at that point we're able to contact the individual and get them to go and see generally what's called a panel physician and transmit the information to that panel physician so that the client can be made aware of their status. I fully agree with you. It is entirely inappropriate that an individual discovers medical information about them for the first time at an immigration meeting. It is entirely inappropriate. So perhaps what we have to do is somehow get through to all clients to always maintain their most current contact with immigration. I have personally had to deal with situations where I've had to track down individuals, you know, going through a series of where they've been living to try and find out where they are so I could contact them, because I was aware that they were going to be refused because they were not complying. And the real reason they were not complying is we didn't know where they were. Okay. With regard to the individual from Nova Scotia, honestly, we're not unreasonable, okay? If a panel physician contacts us and say, hey, you're supposed to have this, 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 but you know, this client has been treated and has been on treatment for an extended period of time, can we can we submit this in lieu? And virtually always we will say yes. Okay, we're not so dogmatic as to deny something that's entirely reasonable. I think part of the problem here we have in Canada is sometimes, as was pointed out, panel physicians say that they don't have time to do counseling and whatever. And one of the things that really hit both of us coming here is that the in-Canada management is not nearly as efficient as the outside of Canada management. Okay? And I think if there's anything, this is a theme that we have to bring back to our headquarters to say, you know, we're going to have to improve how we do our processing within Canada because we are not providing client service. We are not ensuring that clients are treated with respect. In fact, we're treating them as if they are an article rather than a person. Sorry, thank you.
So try to make it brief because we're out of time.
Navi Janjo from British Columbia. First, a brief comment related to delayed diagnosis. So based on some of the studies that we were doing here in British Columbia and some of the data from Ontario, most of that delayed diagnosis may be related to our frontline physicians not understanding an immigrant from an endemic country as a risk factor for screening and not offering screening. So that is one thing that needs to be addressed at the local health level. And that's what we are doing in British Columbia. So second question is to Dominic and George. So we have been struggling with pre-arrival screening for hepatitis versus post-arrival screening because of some of the issues raised by immigrants related to denial and stigma and so on. So what is your, is there any data in terms of linkage with post-arrival care from tuberculosis program to see what would be or how we could implement a post-arrival screening program, let's say for hepatitis B or C, for people coming from endemic countries or so on?
Yeah, the simple or the quick answer is that we don't have one. So when, oh, sorry, okay. So when the notification takes place or there's a transfer information to PTs, then if the PTs doesn't get back to us, we essentially don't have any way to follow up. For instance, if let's say we had notified an individual who had latent TB infection to a province, we have no idea if they developed active TB while they were living in that province. So unless the province, for instance, came back to us and said, oh, just so happens that the individual has active TB, could we potentially have the immigration medical examination with further information? So that's the disconnect that we're working around to trying to see how we could have more of a sense of the continuum from pre-migration to post-arrival. But because we're so focused, oh, okay, sure. Essentially, that's basically it. Sorry about that.
I know there's lots of questions. The panel will stick around here after I close things down, but we're at 2, and out of respect for the next session, I need to close down the questions. Obviously, there's many people who have questions, so I get the impression there's an appetite for more discussion about this. I'd like to thank the panelists for sharing their thoughts and their time. I'd like to thank the audience for participating in this. And again, we'll be here to discuss things further. Okay.